Good day. My name is Adriana Malone, and I am a hematologist and bone marrow transplant physician at Mount Sinai. My goal for this educational session is to take you through two patient cases which highlight key issues of hematologic malignancies in older and elderly patients. I have no disclosures. Our objectives for this session are first, to demonstrate enhanced knowledge of diagnosis and treatment of hematologic malignancies in the geriatric population, and second, to discuss the role of supportive care in elderly patients with hematologic malignancies. First, we will begin with case number one. Miss P is a 70-year-old female with a history of hypertension, diabetes, and hyperlipidemia you are seeing for a scheduled follow-up. She feels well and is asymptomatic. Her physical exam is unremarkable, and you order routine labs for her, including a CBC and chemistry panel. Take a minute to look over her labs and see which are the abnormal results. So after taking a look, you see that the CBC is within normal limits, as is the differential. The creatinine is normal. The total protein is elevated, but the remainder of her studies, including her albumin and calcium, are within the normal limits. What would be the differential diagnosis for a patient with an isolated elevated total protein? This could include dehydration, infection, including HIV, chronic inflammation, or potentially a plasma cell dyscrasia, including amyloid, multiple myeloma, or MGUS. So in order to further evaluate the patient, what studies would you order next? So the labs that are ordered are the multiple myeloma studies. First, the quantitative immunoglobulins are checked, revealing an elevated IgG and a normal IgA and IgM. The SPEP, a test which separates proteins based on physical properties using electrodes with positive and negative charge, size, and shape. Normal results show bands including albumin, alpha 1, alpha 2, beta, and gamma separated out. IgG is typically found in the gamma region, and in our patient, we see a homogeneous spike in the gamma region where the monoclonal IgG is located. Serum immunofixation has primarily replaced the SPEP. It is faster and only sensitive to immunoglobulins. This patient's serum immunofixation demonstrates a monoclonal IgG kappa protein of 2 grams. The free kappa and lambda light chains are also tested for, and the ratio of kappa to lambda bands is normal. Finally, the urine is assessed for evidence of protein in the UA and monoclonal protein in the urine immunofixation, both of which are negative. So what is in your differential diagnosis? Here we have a patient who is asymptomatic with normal organ function, including normal creatinine, normal protein. Here we have a patient who is asymptomatic with normal organ function. The M spike is 2 grams per deciliter with a normal IgA and IgM with no reciprocal suppression. The differential diagnosis is monoclonal gammopathy of unknown significance versus multiple myeloma. So how would we proceed to complete the workup in our patient? So to complete the evaluation, a bone marrow aspirate and biopsy is performed, demonstrating 8% of plasma cells, which on immunohistochemistry are IgG kappa plasma cells. A PET-CT scan is also completed and shows no evidence of FDG-avid lytic bony lesions. And a 24-hour urine protein equally shows no monoclonal protein present. So what is the patient's diagnosis? In this situation, it's an MGUS, and the diagnostic criteria for MGUS are a finding of monoclonal immunoglobulin levels less than 3 grams per deciliter, bone marrow plasma cells less than 10%, no marrow lesion, no bone lesions. The patient is asymptomatic. The uninvolved immunoglobulin levels are within normal, and there is no there's no related organ or tissue impairment. The prevalence of MGUS is 3 to 4% of individuals older than 50 years old, which increases with age. Patients at highest risk are found to have a higher initial M spike greater than 1.5 grams per deciliter, a non-IgG paraprotein, for example, IgA MGUS, as well as an abnormal free light chain ratio. For patients who have a diagnosis of MGUS, the recommendation is to monitor the patient every 6 to 12 months to assess for progression of disease, and this will be with a CBC and serum immunofixation. The risk of transformation to symptomatic multiple myeloma is 1 to 2% per year. So at 25 years is approximately 30%. Patients should not be treated in the stage of MGUS, but should be treated once they progress to overt and symptomatic multiple myeloma. So fast forward 2 years. Miss P returns for a scheduled follow-up once again. However, now she doesn't feel so well. She reports fatigue and progressive dyspnea on exertion for the last 4 weeks. Her appetite is poor, and she has lost 10 pounds in the last 2 months. Also, she has a nagging pain in her back that has not been relieved with acetaminophen or ibuprofen. Review of systems is also positive for constipation. Here are her findings on physical exam. The positive findings include a systolic flow murmur, as well as tenderness to palpation over her spine and her right humerus. Comprehensive lab studies are drawn. Please take a minute to look over the labs. And we see now that in reviewing her CBC, our patient is now anemic with a hemoglobin of 8. The creatinine is elevated at 2.1. The calcium is elevated to 11.5. And on the multiple myeloma labs, we see an elevated IgG of 5,400 with suppression of both the IgA and IgM paraproteins. Overall, her monoclonal protein spike is 5 grams per deciliter, and she has an elevated free kappa lambda light chain ratio of 15.1. The serum beta 2 microglobulin is 6, which is elevated as well. Just take a minute on beta 2 microglobulin. This is a small membrane protein that is associated with the heavy chains of class 1 MHC proteins and is present on the surface of all nucleated cells. Beta 2 is elevated in diseases associated with increased cell turnover. This includes malignancies as well as benign conditions. Non-malignant conditions in which beta 2 microglobulin may be elevated includes chronic inflammation, liver disease, renal dysfunction, as well as some acute viral infections. Malignancies such as multiple myeloma and lymphoma are often associated with an elevated beta 2 microglobulin. And for multiple myeloma, an elevated beta 2 microglobulin is an inferior prognostic factor. If the level is less than 4, is considered favorable. And this should not be confused with anti-beta 2 glycoprotein 1 antibody, which is a test that is used in studying patients for antiphospholipid syndrome. Here is a representative bone marrow aspirate, and here we are able to see an increase in plasma cells. Plasma cells are these large cells which are seen throughout the aspirate, which are large. They have eccentric nuclei, as you can see in the majority. Eccentric nuclei look like a sunny side up egg. The nucleus often may appear to have a clock face, and the cytoplasm is deeply basophilic. And here we actually see a binucleated plasma cell as well. Additionally, on fish testing, fluorescence in situ hybridization, we see that this patient has a deletion 17p mutation, which is a high-risk mutation. On a representative skeletal survey, we see that the patient has diffuse lytic lesions in the right humerus. You can see these punched out lytic lesions throughout. And on the skull, we can also see that there are lesions of various sizes that appear that someone punched out these lesions. This is often considered a Swiss cheese appearance of a skull in a patient with multiple myeloma. And finally, a PET CT scan or MRI is also recommended prior to the initiation of treatment to discern active lesions in the bones versus inactive or treated lesions, or in a patient with newly diagnosed multiple myeloma, smoldering multiple myeloma. The PET scan is more sensitive than plain films, and the PET CT works by detecting the energy that's emitted by positively charged particles. A radio tracer is broken down inside the patient's body. Positively charged particles are made and are then detected by the scanner. And PET CTs are very useful at the time of diagnosis and for follow-up. So the diagnosis at hand is multiple myeloma, accounting for 15% of all hematologic cancers. Here are the 2024 statistics, which overall are quite stable from the prior years. This is a disease of older adults with a mean age of diagnosis, 62 for men and 61 for women, and is seen more than twofold greater in African Americans. The median survival is 5 to 7 years and continues to improve and increase as new therapies are introduced. The classic signs and symptoms of multiple myeloma include lytic bone lesions, which are found in 70% of patients at diagnosis. This is in part due to the increased rate of bone resorption with an imbalance between osteoblast and osteoclast activity. 60% of patients have a normocytic normochromic anemia at diagnosis due to marrow infiltration as well as cytokine suppression of hematopoiesis. 20% of patients present with renal failure, often due to multiple etiologies, including light cast nephropathy, hypercalcemia, dehydration, and hyperuricemia. And 20% of patients have hypercalcemia due to progressive bone destruction. And patients may often present with the classic symptoms of hypercalcemia, including nausea, fatigue, constipation, confusion, and polyuria. Recurrent infections can be especially serious in patients with multiple myeloma due to an increased susceptibility for encapsulated bacteria, including H. flu, strep, and meningitis. And the mechanisms that contribute to increased susceptibility to infections include hypogammaglobulinemia, granulocytopenia, decreased cell-mediated immunity, as well as the prolonged use of steroids. The criteria for the diagnosis for multiple myeloma include either greater than 10%, greater or equal to 10% clonal plasma cells, or biopsy-proven bony or extramedullary disease, plus one of the following CRAB features that signify end organ involvement, including hypercalcemia, renal insufficiency, anemia, or bone lesions, or alternatively, any single myeloma-defining event, including 60% or greater clonal plasma cells in the bone marrow biopsy, a serum involved to uninvolved free light chain ratio of greater than 100, or more than one focal bony lesion on MRI 5 or greater millimeters. Staging a diagnosis is important for prognosis as well as for determining the optimal approach to therapy for our patients. The traditional staging system was the Dury-Salmon staging system, first published in 1975. This was a traditional staging system that truly assessed the extent of tumor and or the size of the tumor. More recently, the international staging system and now the revised international staging system are used and take into account primarily the serum albumin and the beta-2 microglobulin. The revised ISS also takes into account the cytogenetics, which the initial, the ISS did not. And so here you can see the criteria for stage 1 disease, a beta-2 microglobulin of less than 3.5, an albumin 3.5 or greater, no high-risk cytogenetics, and a normal serum LDH. For stage 3, both of the following must be true: a serum beta-2 microglobulin greater than 5.5, as well as the presence of high-risk cytogenetics. The importance of cytogenetics is highlighted by the Mayo Clinic Risk Stratification for Multiple Myeloma, or MSMART assessment, where patients for standard risk may have the presence of trisomies, a translocation 1114, or a translocation of 614. 60% of patients at diagnosis are categorized as standard risk. 40% are high risk, and these patients have the presence of translocation 414, translocation 1416, translocation 1420, a deletion 17p, or a gain of 1q. And so going back to our patient, what stage is Miss P's disease? Using the revised ISS classification system, her beta-2 microglobulin was 6, and she also has the presence of a deletion 17p on FISH testing, leading her to stage 3 disease. And is treatment indicated for our patient? And the answer for that would be yes. Treatments should be indicated for patients with symptomatic multiple myeloma or patients who have end organ damage, including CRAB symptomatology. Again, hypercalcemia, anemia, renal failure, or bony pain. Moving on to treatment, first, a few questions to consider when we think about treatment. And treatment for multiple myeloma is a highly individualized approach. What is our patient's age, her performance status, and existing comorbidities? And is this patient a candidate for stem cell transplantation? When we think about transplant, these transplants are autologous transplants, meaning we have the ability to give patients high-dose chemotherapy with melphalan and then infuse their previously collected stem cells to facilitate a faster engraftment and recovery from the side effects and the myelosuppression of chemotherapy. Autologous transplantation in multiple myeloma has been now performed for over 20 years and has been shown to increase both event-free and overall survival. The typical upper age limit for patients for autologous transplants in multiple myeloma range from 70 to 75, but again, highly individualized based on the comorbidities that are present as well as the patient's performance status. If the patient could be a potential candidate for transplant, then we consider initial therapy with regimens containing either bortezomib or carfilzomib proteasome inhibitors, lenalidomide, which is an immunomodulatory drug, dexamethasone, or daratumumab, an anti-CD38 monoclonal antibody drug. If the patient is not thought to be a candidate for transplant based on age, performance status, and comorbidities. We still may use many of the similar regimens, including combinations containing bortezomib, carfilzomib, lenalidomide, dexamethasone, daratumumab, or cyclophosphamide. In the past, melphalan was commonly incorporated into frontline regimen of patients who were transplant ineligible. And so the reason why we no longer do this is because melphalan can then affect the ability to harvest stem cells. And sometimes it may not always be clear if a patient is a transplant eligible or not at the time of initial presentation. So once we begin therapy for patients, we reassess their response after 2 cycles. And if a patient is eligible for transplantation, at that point, they will be considered for stem cell collection and will pursue transplant. If a patient is not eligible for transplantation, they will continue with their initial induction therapy, and then both groups of patients will segue to maintenance therapy. Lenalidomide, an immunomodulatory drug, is the standard of care for maintenance therapy in most patients. Bortezomib may also be considered. Specifically, for standard risk patients, we incorporate lenalidomide, and then for higher risk patients, bortezomib may be combined with lenalidomide. And again, this is considered after a transplant or after sufficient therapy in non-transplant eligible patients. Supportive care is extremely important for multiple myeloma. Pain management, given the many effects on the bones, potential for pathologic fractures in our patient population. Palliative radiation therapy may be incorporated for the management of uncontrolled pain, or for impending pathologic fracture or impending cord compression. Bisphosphonate therapy, or denosumab, is indicated for all patients receiving primary therapy and has been shown to reduce skeletal-related events. Renal function must be carefully monitored, as well as patients must be closely observed for any dental issues, including the development of osteonecrosis of the jaw. HSV and BZV prophylaxis are indicated for all patients receiving proteasome inhibitors. This would be bortezomib or carfilzomib. Antithrombotic therapy is indicated for patients receiving immunomodulatory drugs, including thalidomide, pomalidomide, or lenalidomide. Patients may need to be supported with growth factors or given IVIG for patients who are hypogammaglobulinemic and who have recurrent sinopulmonary infections, including severe and life-threatening infections. Here are the most common adverse effects associated with the core myeloma therapies. For patients who are on thalidomide, lenalidomide, or pomalidomide, VTE prophylaxis is necessary. The optimal prophylaxis has not been determined, but low-dose aspirin is most commonly used. Bortezomib neuropathy has been shown to be more severe with intravenous therapy than with subcutaneous therapy, so the standard of care is to use subcutaneous therapy. Dexamethasone is incorporated into each of our treatment protocols for multiple myeloma, and as such can be associated with hyperglycemia, common steroid side effects, PCP pneumonia. Carfilzomib has an increased risk of cardiopulmonary toxicity, and we assess patients with a pre-treatment echocardiogram and follow monthly BNP while on therapy. A few final special considerations in multiple myeloma. Hypercalcemia as a presenting symptom is common, and patients need to be treated aggressively with IV fluids, bisphosphonates, steroids, and calcitonin. due to the increased immunosuppression for patients with myeloma, as well as the immunosuppressive effects of therapy. Vaccination for influenza and pneumovax is recommended. Renal dysfunction in multiple myeloma can be due to a myriad of causes. Patients need to stay well hydrated. Recommend to avoid the use of NSAIDs and any other nephrotoxic drugs. IV contrast should be avoided if possible, but is not an absolute contraindication. Patients should be monitored for renal dysfunction with chronic use of bisphosphonates. And if acute renal failure at presentation, patients may be treated with plasmapheresis and concurrent initiation of multiple myeloma therapy. Patients should be prophylaxed against HSV, PCP, and fungus as indicated. And if a patient presents with hyperviscosity, plasmapheresis can be an effective temporizing therapy until definitive therapy can be initiated. Moving on to the second case of today's session, Miss M is an 84-year-old female with a history of hypothyroidism, hypertension, and hyperlipidemia who is also noted to have progressive anemia. What questions will you ask Miss M? Do you have any other symptoms, any chest pain, shortness of breath, or palpitations? We should ask about change in stool color, change in bowel habits, any blood in the urine, any GYN bleeding. Does she have any other medications or other chronic conditions? Any alcohol use? Any change of diet that could suggest a nutritional deficiency, including a folate or B12 deficiency? And what will you look for on her physical exam? Any evidence of anemia or evidence of a hematologic process, including hepatosplenomegaly, lymphadenopathy, pallor of the conjunctiva, any pallor of the nail beds, nail bed blanching, a stool guaiac test. So here are the findings from her physical exam. So she has pale conjunctiva, asystolic flow murmur, but no apparent lymphadenopathy, no hepatosplenomegaly. And so now what labs should we order next? So here are the labs that are ordered. Take a minute to look these over. So here we see that the hemoglobin is reduced at 7.8 with a normal white blood cell count and platelet count, a normal differential, an elevated MCV of 105, a reduced red blood cell count, and a low reticulocyte count. The remainder of her studies, including a TSH, B12, folate, SPEP, iron panel, are all normal, as are her organ exams, including kidney and liver exams. And the stool guaiac test is negative. So first of all, how would we describe this anemia? We see that her MCV is elevated, so she has a macrocytic anemia. The reticulocyte count is reduced, and so it's also important to assess the absolute reticulocyte count by multiplying the red blood cell count by the reticulocyte count. This gives us a sense of, is the bone marrow responding appropriately to the hemoglobin of 7.8? In this situation, the reticulocyte count is only 12,500. If the absolute reticulocyte count is less than 50,000, the bone marrow is not responding appropriate for the level of anemia, and this is a hyperproliferative anemia. So we've checked for B12 and folate deficiency, which can be associated with a hypoproliferative anemia, and we don't see any evidence of that. And so next, we also don't see any evidence of iron deficiency. But next, we should assess the patient for a primary bone marrow process, including myelodysplastic syndrome, myeloproliferative neoplasm, leukemia, and we will first evaluate the patient by reviewing the peripheral blood smear. Here is a representative smear, and we can see that there is anisocytosis present. Anisocytosis is the variety of the sizes of the red blood cells. And we can also see macroovalocytes. Macroovalocytes, so here, for example, is one, is a large red blood cell, and we gauge the size based on the diameter of the nucleus of a mature lymphocyte. And we can see that the red blood cells, the macroovalocytes, are larger in size than the diameter of the mature lymphocyte. We see here a neutrophil, which is morphologically normal, as are the platelets on this smear. Here is an example of a bone marrow aspirate where we see evidence of dysplasia in the red blood cell lineage, especially here we can see. You can see binucleated cells. This is actually, sorry. Here on this slide, we can see evidence of dysplasia in the erythroid lineage with evidence of multinucleated cells and dysynchrony of maturation of the cytoplasm and nucleus. We can see dysplasia in the myeloid lineage as well as small hypolobated polys. On this smear, we see very clearly a multinucleated erythroid precursor showing evidence of dysplasia. One of the most important components of analysis with a bone marrow aspirate is to assess for cytogenetics and more recently next generation sequencing. On this slide, we have a representative cytogenetic analysis, and we can see the karyotype with each pair of chromosomes. On this slide, we see an isolated deletion of the long arm of chromosome 5. And so what is the diagnosis in our patient? We see evidence of normocytic anemia, what is the diagnosis for our patient? We see evidence of dysplasia on the bone marrow biopsy, cytogenetics with an isolated deletion 5q, and an isolated anemia. The diagnosis here is myelodysplastic syndrome with an isolated deletion 5q. This is the most common cytogenetic abnormality in MDS, seen in 16 to 28% of patients. MDS is a bone marrow disorder of abnormal hematopoiesis and maturation. The median age of diagnosis is 70, and as a result of this abnormal hematopoiesis and maturation, cells are not able to leave the bone marrow because of their dysplastic nature, and as a result, patients develop cytopenias with increased risk of symptomatic anemia with a drop in hemoglobin, infection due to neutropenia, and bleeding due to thrombocytopenia. Patients succumb to MDS due to complications of bone marrow failure, as well as transformation to AML. This is a very heterogeneous disease. It cannot be cured except with allogeneic stem cell transplant, and goals generally are to support patients by treating symptoms and to improve quality of life in patients who are not stem cell transplant candidates. We have two primary methods to assess risk of prognosis for patients with myelodysplastic syndrome. We have the IPSS, which uses each of the prognostic variables of bone marrow blast karyotype and the number of cytopenias and assigns a score that is then translated into a total score, which stratifies patients into low-risk disease, intermediate 1, intermediate 2, and high-risk disease. The important thing to note is as patients have a higher score by IPSS, the median survival is dramatically lower in the absence of therapy, and the time to progression to AML is also significantly less. More recently, the IPSS-R has been published and is now being used, and very similar to the IPSS, except the IPSS-R substratifies out the hemoglobin, platelets, and ANC versus singularly looking at these as the number of cytopenias. The IPSS-R has an additional category, and so we have the very low, low, intermediate, high, and very high categories. Similarly, the median survival in the absence of therapy and the time to the progression to AML also decreases as the IPSS-R risk score increases. So our patient has MDS with a deletion 5q. This is a somewhat separate entity and has a more favorable outcome than other patients with MDS, where patients may present with anemia alone, may have normal or elevated platelets at diagnosis, and typically present with a low bone marrow blast count, usually less than 5%. This disease has a unique sensitivity to low-dose lenalidomide, our immunomodulatory drug that we previously discussed in multiple myeloma, and has been shown to cause patients to have a lower transfusion requirement, and also patients may have a reversal of their cytogenetic abnormalities. For other patients who have low-risk disease, other than our deletion 5q patients, this patient population, if they have symptomatic anemia, may be treated with ESAs if their serum EPO level is less than or equal to 500. If they have an elevated EPO level greater than 500, immunosuppression may be considered, or transfusion support may be considered. If patients also have clinically significant neutropenia or thrombocytopenia, they may be treated with a hypomethylating agent such as azacitidine or decitabine, or on a clinical trial if available. For patients with higher risk disease, this is the intermediate 2 and above disease, the first question to ask is our patient a candidate for an allogeneic stem cell transplant for a curative intent therapy? The upper age limit typically is about 70 to the low 70s, again, based on the patient's associated performance status as well as comorbidities. If the patient is not a candidate for transplantation, then we should look to see if there are any available clinical trials, or the patient may be treated with hypomethylating therapy with either azacitidine or decitabine to begin. So now we fast forward 1 year. Our patient is now 85 years old and was initially treated with a trial of lenalidomide. She tolerated this therapy well for the first 6 months, but has now become progressively more anemic. She's here today for a routine follow-up and reports progressive fatigue over the past month, new gum bleeding, and bruising. So what is in our differential diagnosis now? She may have progressive MDS, transformation to acute myeloid leukemia, progressive thrombocytopenia, or she may have disseminated intravascular coagulation, or DIC, with her new gum bleeding and bruising. What labs should we order? A CBC with differential, a complete chemistry panel, and I would also check her coagulation factors as well as her fibrinogen to rule out DIC. Here are her lab results. Please take a look. And so we see that the white blood cell count is elevated at 15.1. The hemoglobin is 7 and the platelets are 25. On the differential, we see 45% blasts. On review of the chemistries, we see an mildly elevated uric acid, an LDH of 450, and on the coagulation labs, we see an elevation of the PT, the INR, and as well as the PTT. The fibrinogen at present appears preserved at 175. Here is a representative peripheral blood smear, and we see one singular large immature cell with a high nuclear to cytoplasmic ratio and evidence of a thumbprint in the nucleus. A bone marrow aspirate is performed, and here is a representative image showing sheets of monomorphic cells that have replaced the hematopoietic elements. And we see very few other hematopoietic elements in the bone marrow. You can see here a few cells that look different, but the vast majority of cells on this peripheral blood smear are the blast cells. And so the diagnosis for our patient is now acute myeloid leukemia, the second most common leukemia in adults after chronic lymphocytic leukemia, with a median age of diagnosis of 69 years old. Here are the 2024 statistics. This is for all new cases and for estimated deaths. This also has remained fairly stable. And so AML in the elderly is a very poor prognosis disease, and this is associated with the advanced patient age at presentation. And given that, the associated comorbid conditions and often poor performance status. But the biology of this disease is different than in younger patients. Here we see a higher risk of drug resistance, as well as a higher incidence of poor risk tumor cytogenetics. Patients also have a history of prior MDS, chemotherapy, or radiation, as well as a high risk of complications from disease and treatment. The classic signs and symptoms in acute myeloid leukemia are related to symptoms due to abnormal blood counts, coagulopathy, enlargement of the liver and spleen, lymphadenopathy, or due to systemic B symptoms. And treatment considerations, again, a highly personalized approach needs to be taken, incorporating the patient's age, performance status, comorbidities, a side effect profile of any therapies you are planning to treat the patient with, as well as the duration and location of treatment. Is this going to be an oral medicine, an IV medicine? Does this require an inpatient or outpatient treatment plan? And really the goals of care for the patient, given the high risk and often poor prognosis diagnosis. So taking that into account, a clinical trial should be considered if available. If the patient is young and fit, then or younger and fitter, then standard induction therapy can be considered. The most common approach to this patient population is currently treating patients with hypomethylating agents, including azacitidine or decitabine alone or in combination with venetoclax. Low-dose cytarabine can be considered. Gemtuzumab ozogamicin, which is a targeted drug to CD33, which is on the surface of the myeloid blast cells. If a patient has an IDH2 or IDH1 mutation, we have two targeted medications for this patient population. Or alternatively, best supportive care can be considered with hydroxyurea to control a patient's counts or transfusion support. And so finally, a few take-home points. So please include multiple myeloma and MDS in your differential for patients with anemia and without a documented nutritional deficiency. Monitor patients with MGUS and smoldering multiple myeloma closely for evidence of progression to overt multiple myeloma. Optimize supportive care for symptom management of patients undergoing all therapies. And carefully consider a patient's performance status, comorbidities, and goal in treatment planning. Thank you for your attention. If you have any questions about the content of this talk, please reach out to me through email at adriana.malone@mountsinai.org. And we have one post-test question. We have a 76-year-old female who presents with 1 month of fatigue, dyspnea and exertion, and new back pain, which has not been relieved with acetaminophen or ibuprofen. On your initial lab evaluation, you find the following: hemoglobin 7.6, elevated total protein of 10, IgG 4,472, IgA and IgM less than 20. Serum immunofixation reveals monoclonal IgG lambda protein. A PET-CT shows diffuse FDG-avid lytic lesions throughout the spine. What is your most likely diagnosis? A, smoldering asymptomatic multiple myeloma. B, monoclonal gammopathy of unknown significance, or MGUS. C, lambda light chain amyloidosis. Or D, multiple myeloma. And so the answer is multiple myeloma. The patient is found to have monoclonal IgG lambda protein with elevated IgG and evidence of CRAB features, anemia, diffuse bony involvement with lytic lesions on PET-CT consistent with a diagnosis of multiple myeloma. Thank you.